In a fast-moving hospital corridor, a patient's condition is communicated through urgent, subjective language. Doctors and nurses rely on human narratives, describing pain, observing symptoms, and writing quick notes to capture the reality of a medical emergency. But the multi-trillion-dollar infrastructure backing these hospitals operates on a different frequency. The massive databases that process payments and track national health outcomes cannot interpret a doctor's messy handwriting or subjective descriptions of pain. To function, the healthcare revenue cycle demands standardized, quantitative data. Before a hospital can trigger the financial adjudication process, the system that actually pays for that stretcher and those doctors, the human narrative must be converted into strict code. This translation happens through the electronic health record, or EHR, vocabulary. It serves as the necessary bridge connecting the fast-paced reality of the clinic to the precise mathematical demands of the billing department. The first core pillar of this vocabulary is the International Classification of Diseases, commonly known as ICD. Simply put, an ICD code answers a single foundational question: what exactly is the patient's problem? The second pillar is Current Procedural Terminology, or CPT. While ICD identifies the disease or injury, the CPT code answers the operational question: what treatment or procedure was performed to fix it? Both codes are required to complete a patient's chart, but the foundational trigger for any insurance claim rests on proving medical necessity, and medical necessity is established by the ICD diagnosis. The ultimate objective of a medical coder is to read through a doctor's qualitative clinical notes and accurately distill them into flawless financial syntax. The ICD-10 system achieves this translation through a core architectural thesis known as progressive alphanumeric specificity. Every single character added to an ICD string narrows the scope of the data. It acts as a funnel, filtering the information down from a broad category of disease to a specific anatomical reality. To see how this filtering process actually works, we need to build a code from scratch using a real-world test case. Imagine a physician writes the following clinical note exactly like this: closed torus fracture to the right radius, initial exam. Trapped within that single sentence are all the distinct variables the machine requires: the type of injury, the specific shape of the bone buckling, the exact limb, the laterality of left versus right, and the current status of the patient's encounter. If these variables are not perfectly mapped into a machine-readable string, the insurance claim will be automatically denied, and the hospital will not be paid for the treatment. To secure that revenue, we have to run the doctor's sentence through the strict hierarchical rules of the ICD-10 CM format. This table outlines the master template for ICD-10 coding. The format has 7 blank slots divided by a period. Characters 1 through 3 identify the broad diagnosis category and location. Characters 4 through 6 define precise anatomy and other critical clinical facts. Finally, the 7th character slot acts as a unique extension. This space is reserved for tracking the status of the encounter itself, telling the payer if this is a new or ongoing issue. Let's set up a clean digital workspace. We have our 7 empty slots, separated by the decimal, ready to build our torus fracture code. This rigid framework forces qualitative medical ambiguity into absolute auditable data. We begin the derivation process by isolating the primary noun in our physician's note, fracture. This table shows the categories of ICD codes. We must locate the alphabetical category for fractures within this index. Down at the bottom, we find the block labeled S00 through T88, which covers injuries, poisoning, and consequences of external causes. Based on this block, our code starts with the letter S. Next, the subcategory for injuries to the elbow or forearm gives us the number 5. Moving further down the forearm to the lower end of the radius bone provides the number 2. At this point, the broad category and general bodily location are mapped, satisfying the first block of the syntax. We now insert our mandatory period delimiter to cap off the category before proceeding to the granular details. These first 3 characters, S, 5, 2, point, have successfully anchored the hospital's claim to a specific quadrant of the patient's body, but on their own, they lack the detail necessary to trigger full reimbursement. To complete the code, characters 4 through 6 require us to extract the finest pathological details from the physician's writing. We isolate the word torus. The specific bone buckling translates to the number 5. The right radius dictates the number 2. Finally, it is a closed fracture, meaning the bone didn't pierce the skin. This assigns the number 1. We pause at the 7th character slot. Remember, this extension does not describe the physical injury itself, but rather the phase of the patient's treatment. We look at the final piece of the physician's note, which plainly states this is the initial exam. This requires the alphabetical extension A. Our code is now complete. Through this process of progressive specificity, a subjective, human-written sentence has been successfully engineered into a precise, machine-readable 7-character string. Once validated, this string moves out of the clinical space and immediately populates empty fields across the hospital's financial databases. This generates an immediate operational impact. The EHR system reads this specific code to automatically prioritize the facility's financial collection activities. The string dictates how revenue cycle staff are assigned to the patient's account, sorting the workload based on the expected payer and the clinical complexity of the diagnosis. For a massive portion of these claims, the ultimate destination is the federal government. This graphic from CMS highlights that approximately 50% of all healthcare revenue originates with Medicare and Medicaid. These federal entities rely on standardized procedures for monitoring the adjudication process. They do not have the manpower to read subjective clinical notes. They verify the accuracy of the alphanumeric syntax. This diagram illustrates the payment pathways. Whether a claim goes to Medicare, Medicaid, or a private insurance marketplace, this alphanumeric string provides the specific validation required to finalize the accounts receivable process, converting the chart into actual revenue. The financial health and survival of any medical facility rests entirely on the precision of this diagnostic translation layer.